Jacobs, and welcome to this session. I just wanted to point out that to participate, you should be logging on to live.rsna.org, like it says on the slide, so that you can participate on your personal devices. live.rsna.org. So I just wanted to welcome you all to the first session, jointly sponsored by the North American Society for Cardiovascular Imaging. This is the oldest radiology predominantly run cardiovascular imaging society, and it is multimodality. It's a great society. We actually have an upcoming annual meeting in October of 2017 in San Antonio, Texas. So I encourage you all to come and attend. We have some really great educational sessions. And then importantly, to obtain a certificate or to claim CME for this course, you're going to go to Credit Eval on the RSNA iPhone app or visit rsna2016.rsna.org. And just so you know, each session this year you can individually claim CME credits for. So if you go to each session, you can claim CME credits independently for each of the sessions that you see. Okay, so without further ado, we're going to begin. Our first speaker is Dr. Prachi Agarwal, who's going to be talking about normal coronary anatomy.
Thank you very much, Jill. It's a pleasure to be here. So I'm going to start off with coronary artery and also touch upon a little bit about cardiac anatomy today. Before we get started, I'm just curious to know the composition of this audience. It'll also help us test our audience response system. So can you please go ahead and answer this question? How would you best describe your scope of work? Are you a general subspecialty imager who does cardiac imaging? Do you do exclusively cardiac imaging? Are you looking into doing it in the future? Are you a member in training or other? Okay, so it looks like quite a mix, but the big portion of the pie is really A, and that is my category as well. I'm a cardiothoracic radiologist, so I do both thoracic and cardiac imaging, but the majority of my work is cardiac related. I also see a fair number, actually almost 1/4 of the audience is members in training, so I really hope that this talk is going to be beneficial to you. So the learning objectives for the next 45 minutes are to talk about normal coronary artery anatomy. I'll also talk a little bit and touch upon the angiographic projections and correlate them with volume rendered images obtained from CT. We'll touch upon the variant anatomy, their potential significance, review coronary artery territories, and finally, I also want to talk about coronary venous anatomy, which is an often neglected subject. So in the beginning, I'm going to show you 3 case-based slides. Do not use your audience response questions for these 3. We will revisit them later again in the lecture, but it will give you a sense of what to expect in the lecture and also be a kind of a self-assessment. So here is the first case, and you're looking at a volume rendered image. The arrows are pointing at a very tortuous collateral structure. So what is the name of this preconal collateral network? Just think about it in your minds. As I said, we'll talk about these later. So here is the posterior view of the heart. The arrow points to a vein. So the question is, what is this coronary vein? And finally, in this patient, he was found to have coronary sinus osteoatresia. So here is the osteoatresia. He was also incidentally found to have a persistent left SVC. So with these 2 things in mind, what do you think would be the significance, the hemodynamic significance And can you anticipate the direction of blood flow in the persistent left SVC in such a case? Okay, now let's get started. As radiologists, we are very tuned to looking at axial images. The angiographers look at 2D images, and I'm hoping not only to talk about the axial imaging, but also to weave in volume-rendered images and hopefully explain the angiographic projections. So normally there are two ostia, one for the left main artery, the other for the right coronary artery. And we'll start off with the left main coronary artery first. As we know, it typically arises from the left sinus of Valsalva, and it soon after bifurcates into the LAD and the circumflex artery. Now, depending on the variation at the length of bifurcation, the left main can be of varying sizes. It can be very, very short, as in this case if the bifurcation happens early. In fact, you might have no left main at all, and the LAD and the circumflex might arise separately from the aorta. Another common variation we often encounter is to have a trifurcation. So apart from the LAD and the circumflex that you're seeing here, there's a third vessel in the middle, which is termed the ramus intermedius. Now, this has important implications when you're looking at coronary artery territories, and I'll show you a case later on in my presentation to illustrate this. Starting off with the left anterior descending artery, the hallmark is that this artery resides in the anterior interventricular groove, which you can see both on the axial images here, so between the right and the left ventricles anteriorly, and on the volume-rendered image here. So here is our LAD. Let's view it on the axial images. So I'll just show you a stack of few images. Here is the left main. This is where it's bifurcating. Here is the left anterior descending artery. And if you keep following the arrow, you can see that it's maintaining its position in the anterior interventricular groove and then wraps around the apex. The branches of the LAD are two important sets. One is the diagonals, which, as the name suggests, course diagonally on the surface of the left ventricle. So you can see a set of diagonal arteries here. You also have the septal perforators, which arise typically from the underside of the LAD, and they dive into the septum, supplying it. So let's look at the axial stack of images and see how we can identify these LAD branches. So as I'm scrolling through, this is our left main dividing into the LAD and the circumflex. Keep looking at the LAD. So here is our LAD, and one of the important branches you're seeing is coming off right here. If you follow this branch, you can see that it's coursing on the surface of the left ventricle. So this is our diagonal. There is another diagonal coming off right here, and the LAD itself remains in the anterior interventricular groove. So this is the LAD and a diagonal coming off, supplying the anterior aspect of the left ventricle. Now, if you look at the other set of branches, so here is a very, very tiny septal perforator coming off, diving into the myocardium. Here's another one extending into the septum, and a third one. And talking about the branches, it becomes important to understand the segments. How do we define the LAD segments? And as we will go into more and more case-based review sessions, we talk about coronary artery diseases, and there it becomes really important to know how you define the segments, how you would report it, to be on the same page as the referring cardiologists. So it's divided into three segments: the proximal, middle, and distal. And by convention, this is done using the diagonals. So you can see the origin of the first and second diagonals. So from the origin to the first is proximal, between the first and second is mid, and thereafter it's distal. Now, because these diagonal origins are so variable, you can have extremely variable lengths of the proximal, middle, and distal LADs, as you see in this case. Now, this is something very typical we see. So you have a really short proximal segment, short middle segment, and then virtually the entire LAD is a distal LAD. In this case, however, if you notice, there's a relatively big proximal segment. Now, one of the reasons here could be the fact that you have this ramus intermedius branch, which has a territory similar to a diagonal and circumflex obtuse marginal artery. So it's for this reason, because of the ramus intermedius, the first diagonal is coming off relatively late, and if you have a longer proximal LAD segment. Moving on to the left circumflex artery. This is a vessel that resides in the left AV groove, as you can see here, between the left atrium and the left ventricle. Here it is on the volume rendered image. We're looking at it from a posterior view. So here is our left atrium, ventricle, and the circumflex artery residing in the left AV groove. So again, if you follow this, this is our left main. The arrows are pointing to the circumflex. The LAD, as we talked about, is lying in the anterior interventricular groove. You keep following it, and you can see that the circumflex resides in the same location. The important branch of the circumflex is the obtuse marginal branches, which supply the lateral wall of the left ventricle. So here is our circumflex artery, and this is an obtuse marginal branch. As you can see, it's supplying the lateral wall of the left ventricle. So let's see the circumflex and obtuse marginals on a stack. Left main dividing into LAD and circ. The circumflex, you can see, maintains its position in the AV groove, and here it's dividing into two. So if you look at the anterior vessel, that's the bigger caliber vessel, and that is actually your obtuse marginal, which is supplying the lateral left ventricle. The circumflex itself typically becomes quite small after it gives off the obtuse marginal, but the key is to see its location in the AV groove. So here is our circumflex. The circumflex segments are very, very easy. It's divided by the obtuse marginal artery. So prior to the origin of the obtuse marginal is the proximal, and typically, like I said, after the origin of a major obtuse marginal, the circumflex artery becomes relatively small, so then that is called the distal circumflex. Now let's touch upon the angiographic views, and my idea is not to do a comprehensive review of these projections, but only so much that you get comfortable looking at these angiographic views, particularly when you're reading a coronary CT angiogram. So there are various views, and I'm not going to talk about all of those, but there are a few guidelines how you can identify these tomographic views. And the most important thing you look for is the catheter in the descending aorta and the position of the spine relative to the image. So if these two structures are to the right of the image, then it's going to be an LAO projection and vice versa. So here it is. We've got this projection here, and what you notice is that this is the spine and it is to the left of the image. So as I mentioned, this is likely to be a right anterior oblique projection. The other thing to look for is how has it been angulated, the tube? Is it a cranial projection, caudal projection? And what they look for is the diaphragm. So if you can see the diaphragm, like you can see it here, it's likely to be a cranial view. So this is a right anterior projection with a cranial view. And now the question is, what are these vessels that we are seeing? Can we identify these left-sided vessels? We can clearly see it's a left vessel, but which is the LAD, which is the circumflex? So remember, it's a right anterior oblique projection. So what happens is the interventricular groove, the anterior interventricular sulcus, moves out towards the margin of the heart. So this is where the anterior interventricular sulcus lies. So this big vessel that you see very nicely in profile is going to be your LAD. The circumflex artery comes to lie in the center of the image. It's actually coursing along the posterior aspect, but I used a transparent view so you could see that how it projects on an angiographic view. Moving on to this view. Now again, we can see that the catheter is to the right. So this is going to be an LAO projection. Now we're rotating in a different way. So what happens is the anterior interventricular groove is now coming to lie in the center of the image, and this is going to be our LAD, and the circumflex moves out. Now, it's something that you can, when you're doing CTs, it's always a good idea to look at these volume rendered projections. It's very, very easy to rotate these models around and get comfortable with the different views. One of the variants I want to touch upon today is dual LAD. And it's because it has some important implications, which I'll discuss in a few minutes. But what it means is that there are two vessels in the anterior interventricular groove. So here is a case of a dual LAD. And again, let's get reoriented to this image. This is our right ventricle, giving rise to the pulmonary artery. Here is our left ventricle. So this is the anterior interventricular groove, where lies this structure, which is our LAD, as we talked about by definition. But what you notice is that this LAD terminates relatively quickly, doesn't really go for the whole length. So what's happening is that there is this other bigger vessel which is coursing parallel to the short LAD for a variable distance, and then more distally it enters into the anterior interventricular groove, in fact wraps around the apex. So this is our long LAD. So we have two LADs in the anterior interventricular groove. Now this is not a diagonal, even though it seems to be a branch of the LAD. This is not a diagonal. The reason being it's not coursing diagonally, but rather courses parallel initially and then enters, very importantly, into the anterior interventricular sulcus, making it an LAD. Now, what is the importance of this variant anatomy? Well, one thing is with CT, we are now seeing an increasing prevalence. We are noticing this abnormal or this variant pattern a lot more. This paper reported a prevalence of 4%, which is higher than what's been usually reported on conventional angiography. But what's important is that you want to convey this information to the surgeon, because there is definitely a potential for revascularizing the wrong LAD or doing an inefficient or deficient vascularization. So important thing to mention in your report. Also, there have been reports in literature where on angiography, this was misconstrued as a mid-LAD occlusion. The reason being that the angiographer did not visualize the long LAD, which was coming off from the right sinus. So they did not expect it, it wasn't seen, and therefore that short LAD was misconstrued as a mid-LAD occlusion. With CT, we have this 3D data, we have a great look at the vessels, so this really helps us. Being aware of this variant anatomy is very important. Also, it can lead to unusual patterns of wall motion abnormality depending on which LAD is involved. Now, moving on to the right coronary artery, it typically arises from the right sinus of Valsalva and courses in the right AV groove, usually because it's a right dominant system, so it terminates in the posterior descending artery and the posterolateral branch. One thing you'll notice is that I've been saying it typically arises from the right sinus of Valsalva. The reason is when we define coronary arteries, they're not defined by their origin, but rather by their dependent territory. And following me, Dr. Seelan Javedan is going to talk about coronary anomalies. So what you'll notice is that the vessels can arise from the wrong sinuses, but what's very important is the dependent territory. That's how we name a vessel. So what is that artery supplying is the reason for naming it as a right or a left coronary artery. So here is, again, looking at our angiographic projections. You can see this is our spine, this is the catheter and the descending aorta. These are both to the right of the image, so it's an LAO projection. And this nicely opens up the right coronary artery. We see a nice C-shaped appearance and course. How does it look like on axial imaging? Well, one thing I find is in the RCA, you have very distinct regions. The first part is where it looks very, very horizontal. And if you're looking on axial images, you catch the vessel pretty much in long section. And then fortuitously, a significant portion of the RCA courses in a plane which is perpendicular to our axial images. So we get a very good assessment of the right coronary artery on simple axial images alone. And finally, again, it takes this horizontal bend. So again, we start catching the vessel in a longitudinal section. So what are the branches? The first branch in a little over half the patients is a conus branch, which, as the name suggests, supplies the conus or the right ventricular outflow tract. So here is the conus branch, you can see on this volume rendered image. But what happens in the other 40 to 50% individuals is that the conus may just arise separately from the aorta and not as a branch of the right coronary artery. Here is an axial stack of images, so let me show you the conus branch. You're already seeing a vessel here coursing to the RVOT. As I keep scrolling it, you can see it's coming off the right coronary artery. So here is our right coronary artery, here is the conus branch, and then it moves around, courses anteriorly, and supplies the RVOT. A very important thing to remember about the conus is that it can serve as a collateral supply between the right and left systems. So let me show you this case. Here is a volume rendered image. Again, let's look at the anatomy first. So here is our right ventricle, left ventricle, anterior interventricular groove. So this is going to be our LAD. And even though we don't diagnose coronary artery disease based on volume rendered images, what you notice is that this LAD is heavily calcified and looks very diseased. This is our right coronary artery between the right atrium and the right ventricle. And we're looking at this very prominent vessel which has the location of the conus, but it's very tortuous, it's dilated more than you would normally see. So this is, in this particular case, serving as a collateral vessel. This patient has had prior bypass grafts. So here is our LAD. This patient's got prior bypass graft. So here is a graft, and if you follow it, you can see it's going to the lateral left ventricular wall, so it's going to the OM territory. There are other occluded bypass grafts as well. Let's look at a few axial images. So here is this collateral that we see, the preconal collateral. It's plugging into the LAD, which looks extremely diseased. And then, if you follow down, you would see that this was actually serving as a collateral to the septal perforator branch of the LAD. So this brings us to our audience response questions. If you could use your mobile devices to answer this question. What is the name of this preconal collateral network? Is it Kugel's anastomotic pathway, Vuessen's ring, or Thebesian? Okay, so most people think it's Kugel's anastomotic pathway. Well, I will tell you that there is a collateral pathway known as Kugel's anastomotic pathway, and I'll show it to you in a few minutes. But the correct answer here is Vuessen's ring. This is a preconal collateral pathway. Oops. So here is an example. Here is a picture which was published in JACC Imaging, and it shows the different collateral pathways. And you can see that this preconal collateral pathway is known as the Vuessen's ring. There's also a retroconal collateral pathway. The one that the majority of the audience thought was the answer is the Kugel's pathway, which happens to be a retroaortic collateral pathway. Now, one of the distractors, and this is simply because I was running out of ideas for a possible distractor, I put in was a Thebesian. It's not any kind of collateral pathway, rather it's the name of the valve that guards the orifice of the coronary sinus, and it can be very variable in extent. It can range from barely being seen to being almost a complete fold, as you see here. Okay, so getting back on track, let's get back to the branches of the right coronary artery. After the conus branch, typically the second branch is the SA nodal branch. You can see it's coursing posteriorly, heading towards the sinus node, and this happens in about 60% of the individuals. In the others, you can also see the SA nodal branch arising from the circumflex, which you can see here coursing retroaortic. One of the most important branches is the acute marginal branches, which supply the right ventricular free wall. So I'll show it to you again on the axial images, the right coronary artery branches we have so far reviewed. So here is our conus branch. If we keep following it, you can see this is our SA nodal branch. The right coronary artery is coursing again in the right AV groove. And here you can see a very prominent vessel coming off. This almost comes up right just before it's bent from that vertical to the horizontal segment. And you can see that this acute marginal branch is supplying the RV free wall. And finally, like I said, since most systems are right dominant, you can see that it's terminating as a posterior descending artery. And often it'll give off the posterolateral branch where it crosses the crux. As you can see here, it's coursing over to the left side and supply the posterobasal left ventricle. The last branch, which is often very small, is the AV nodal branch. And in fact, some authors consider the artery that gives off the AV nodal branch to be the one that is the dominant vessel. So in majority of individuals, the AV nodal branch comes off the right coronary artery. In terms of segments, the RCA is again divided into 3 segments. The demarcation of the distal segment is right where that acute bend is. And then from the origin to this point is divided into roughly halves into proximal and middle. But it's easier to conceptualize the RCA in my mind as almost a horizontal segment, vertical segment, and then a horizontal segment again. Now, what are the different variants that can happen? You can have a much higher than normal origin. It's typically called a high origin if it's more than a centimeter above the siniotubular junction. So instead of arising from the sinus of Valsalva, it's arising above the ST junction. You can have an intracavitary course, and that can predispose this to injury. The next part is dominance, and I think this is a really important thing that we should mention in all our reports. Apart from the technical adequacy of the study, there should definitely be a mention of the coronary artery dominance. And how do we define it? Well, one way was AV nodal branch, which we talked about, but that's often hard to see. So what we look at is which vessel gives off the posterior descending artery and the posterolateral branch. And in most individuals, 85% or so, it's a right dominant system. The other 15% is a roughly half and half split. You can have a left dominant system or a co-dominant system. So let's look at this. This is a posterior view of the heart. Here is the right atrium, right ventricle. So this is our right coronary artery giving rise to the PDA and the posterolateral branch. And what you notice is on the left side there is a good sized OM branch, but the circumflex itself is really, really small. So when you have a right dominant system, the contralateral vessel is usually small. We look at the other extreme example. So this is a left dominant system, left atrium, left ventricle, left AV groove. You can see the circumflex is giving off the PDA, and this is supplying the posterobasal left ventricle. And again, in contrast, you can barely see a right coronary artery here. So the contralateral vessel is again quite diminutive. The co-dominant system is described in multiple ways. It could be, you might have two PDAs coming off, one from the left and one from the right coronary artery, or you can have one vessel giving off the PDA, the other giving off the posterolateral branch. So as in this case, you can see that the right coronary artery is giving the PDA, but doesn't quite continue beyond it, and the posterolateral branches are coming off the circumflex. Also, you can see how these two vessels are very well balanced in terms of caliber compared to the other two examples of right and left dominance that we just saw. Now, one of the importance of coronary dominance, apart from the therapeutic decision making, is that it's been shown that the left dominant and the co-dominant systems have a higher in-hospital mortality, especially among patients who have left-sided coronary artery disease. And the reason is, if you think about even a right dominant system, majority of the myocardial supply to the left ventricle actually comes from the left coronary artery, even if it's a right dominant system. So if you have a left or a co-dominant system, this imbalance becomes even greater, and this is somewhat of an unfavorable anatomy if you have a left-sided coronary artery disease. So these patients have been shown to do worse than the right dominant systems. Let's move on to coronary artery territories. Once we've talked about the normal anatomy, I want to discuss a little bit about the territories, about how you set up the planes, and the various cardiac planes themselves. So one thing that's unique about cardiac imaging planes is the way the heart sits in the thoracic cavity. So it's not really amenable for straight axial imaging, sagittal or coronal imaging. But you need to have specialized planes which are either long axis planes that are directed through the LV apex. So planes that are going through the true LV apex are long axis planes. And the two most important ones we think about are the 4-chamber and the 2-chamber planes. And then you have the short axis planes, which are roughly perpendicular to the ventricle. So let's look at these planes. I want to just give you a few concepts about these planes, and then I'll show you how you can set these up. So we'll start off with the vertical long axis, also known as the 2-chamber plane. And as you can see, this is a vertically oriented plane which is going through the true LV apex. So what you get is the left ventricle, you see the mitral valve very well, and then this is our left atrium. Now you can have another long axis plane, but in this case, this is horizontally oriented. So this is also known as a 4-chamber plane. Almost looks like an axial image, but this is obliqued in a way that it's going through the LV apex, and you can see all the 4 cardiac chambers along with their AV valves. Now using both the long axis planes, if you slice it up in a way that you're perpendicular to the ventricles, you get what's termed as the short axis views. Great view to looking at both the ventricles. We're at the mid-cavitary level, so you can also see the papillary muscles on the short axis views. So how do we set these planes up? Well, the way I would start off with an axial image, and this is important whether you're doing CT or if you're getting into doing cardiac MR, because often you'll be at the scanner and you will want to set these planes up. So start off with an axial, and if you draw a plane going through the apex, right here, through the middle of the mitral valve, and you can scroll up and down to make sure you're going through the apex on multiple slices, you get an image like this. It's your 2-chamber or vertical long axis view. Now from this view, if we go roughly parallel to the AV valve, we are getting a kind of short axis. It's not a very true short axis because it's been made of a single plane, so we want to tweak it of the other long axis view as well. But for now, let's just keep it as our standby short axis view. Now using this short axis plane, what you can do is you can set up your 4-chamber, and the way we do it is use a plane going through the anterolateral papillary muscle and the acute margin of the heart. And at the same time, you want to make sure that you're going through the true LV apex on the other two-chamber view as well. And when you do this, you get a nice four-chamber image. Now, as you remember, we mentioned that this short axis was not a perfect short axis. So what we can do is at this point, we can tweak it. And using both our long axis views, we can ensure that we are cutting the ventricle up in a perpendicular fashion, so we can tweak our short axis image at this point. One of the other planes that I did not talk about earlier is a three-chamber plane, also known as the LVOT view. And it's in fact not only an LVOT view, but it's both an inflow and outflow view of the left ventricle. So here is the left ventricle. You can nicely see its inflow, the mitral valve. You can see the outflow into the aorta. So how do we set up a plane like this? Well, one very easy way to do is take your short axis image, and now we've got this short axis image near the base of the heart. So here are our mitral leaflets, the anterior and posterior mitral leaflets. This is the aorta. So if I draw a plane that goes like this through the aorta, it's going to go also through your mitral valve, left atrium, and left ventricle. And to get a good long axis view, you want to make sure that you're going through the LV apex on the other long axis views. And this will give you a nice three-chamber image. Okay, moving on to the myocardial segments. So there are 17 segments, and I think it's very important that we understand where these segments are located on both the short axis and the long axis views. So let's talk about these 17 segments. And what we do is we divide the LV cavity into three parts. We have the basal level, where we are closer to the mitral valve. You're at the mid-cavity level when you're seeing these papillary muscles, and then beyond it, you're at the apical level. So what are these 17 segments? And I'll show you these segments one by one on the short axis images, and we'll correlate them on the other long axis views. So this is our anterior segment. This is the same segment on the basal, mid-cavity, and apical views. Now, where would we see it on the, let's say, four-chamber image? Well, if you remember, the four-chamber image is oriented like this. So you're not really going to see the anterior wall very well on a four-chamber image, but you see it very well on a vertical long axis view right here, because the vertical long axis goes like this. So we see the anterior wall on the vertical long axis image. The diametrically opposite segment is known as the inferior wall, which you can again see it at all the three levels. And by the same token, you see it nicely on a two-chamber image, not so well on a four-chamber image. Now we are left with the septum and the lateral wall. And here is where the basal and mid-cavity segments are a little bit different from the apical view. So we'll talk about the basal and mid-cavity first. The septum is divided into two segments, the anteroseptal segment, which is closer to the anterior wall, and the infroseptal segment, which is closer to the inferior wall. The only difference from the apical is that it's termed as a single segment at the apical level. So where do we see it? This is easy to guess. You can see the septal wall nicely on a four-chamber image. And the same thing applies for the lateral wall. So again, we have these two segments. We have an anterolateral segment, infralateral segment. At the apical level, we have a single lateral segment, and again, nicely seen on a four-chamber image. So if you think about it, we've already got our 16 segments. These are 6 segments at the basal level, 6 at the mid-cavity, 4 at the apical level. So we have 16 segments. What is that 17th segment? Well, it is the true LV apex. And this is one segment that you don't see very well on the short axis image, but you really need a good long axis view to see the true LV apex. So again, let's use the audience response question. Which myocardial segment is shown by the arrow? And we're looking at this wall. So which segment do we think it is? Is it anteroseptal, infroseptal, anterior, or anterolateral? Okay, let's see what the answer is like. And you're absolutely correct. Almost everybody got it right. So it is indeed anteroseptal. Some people thought it might be the infroseptal, but let's see why we think it's an anteroseptal segment. Now, what's really easy to think is, remember how we set up our three-chamber view. At a basal level, we went like this. And if you remember, this is the anterior wall, this is inferior. So what we'll be cutting through will be the anteroseptal segment. So this is our anteroseptal segment. By the same token, what we're cutting here is going to be our infralateral wall on the three-chamber image. And at this point, let's talk about the coronary artery territories. This is really easy to understand since we've already talked about the segmental anatomy now. Just remember where the vessels lie. This is the anterior interventricular groove, location for the LAD, so supplies the anteroseptal anterior wall. This is the posterior interventricular groove, location for the PDA, so this takes over the infroseptal and the inferior walls. The lateral walls are supplied by the obtuse marginal via the circumflex, and then we have the true LV apex that's supplied by the LAD. So this is a 17-segment representation in the bullseye, and you can see the coronary arterial territories. Now here is the case. This is the patient who had infective endocarditis, had a septic embolism to a coronary artery, very rocky course. During his hospital course, he had this massive infarct. And here are the images. So again, if you could please use your audience response questions to answer this. Hopefully we should be able to see the, great. So here are the cine images of a CT. And this is a bullseye representation where you're showing the abnormal segments by the blue color. So all the blue colors represents abnormal segments. So which coronary artery territory do we think is involved here? Is it the left main, LAD, circumflex, or the right? Okay, so this is indeed correct, absolutely right. This is indeed the LAD territory. I see quite a few people also mention 23%, mention the left main, and it's a good thought, but the only difference here is that what you notice is that the lateral wall is actually relatively spared. In fact, you can see a green and red color here, which is in the normal range. So this would have been the circumflex territory, and if it really was a left main involvement, you should see a coronary artery territory involvement of both the LAD and the circumflex. Now, what we talked about right now is kind of a simplistic approach because it pertains to a very standard coronary artery anatomy with a right dominant circulation. But if you're interested, I would certainly suggest you read these papers. They've talked about how you should be integrating the true coronary anatomy with the myocardial territories. So to exemplify this, I want to show you this patient. This came in, it's not a CT case, but it's a really good learning case. So this patient came in with severe LAD and right coronary artery disease and had this MRI performed. So look at the MRI, and we have these mid-ventricular going in towards the apical level. And what we notice is that the anteroseptal, infroseptal, inferior walls are involved, which is not surprising since this patient has LAD and RCA territory. But what we notice is that the anterior wall is relatively spared. So why do we think the anterior wall is spared in this case? So at this point, let's turn our attention to the angiogram. Again, if you look at the angiogram, we've got the catheter to the left of the image, so it's an RAO projection. So this is going to be our LAD, this is going to be our circumflex. We can definitely see very severe disease in the LAD. But what explains this anterior wall sparing is this vessel here, which is our ramus intermedius. And the ramus has usually a distribution to the anterior wall as well as the anterolateral wall. So that explains why, despite severe LAD disease, you have sparing of the anterior wall in this case. The last part of my talk is coronary venous anatomy. And I want to talk about a few key aspects of the venous anatomy. So there are various components to it. The biggest one we think about is coronary sinus and its tributaries. There are also anterior cardiac veins, which are smaller veins that drain directly into the atrium. And finally, very, very tiny veins called the Thebesian veins. What I want to talk about today is the coronary sinus and its tributaries, because this is something we see on imaging and it has relevance practically as well. There are various tributaries, and we'll talk about these one by one. So here's a volume rendered image. And again, if you recognize, this is our anterior interventricular groove here. So the vessel, the coronary artery that lies here is the LAD. Now you can see there is a vein accompanying it. And it's very easy to remember its terminology, anterior interventricular vein, because that's where it lies, accompanies the LAD. Very soon it makes this abrupt turn, goes into the left AV groove, and this is where it's termed as the great cardiac vein. So now let's turn the heart around. We're looking at it from its posterior aspect. This is part of the great cardiac vein we had already seen. And at some point, this great cardiac vein transitions into the coronary sinus. I'll show you where, but in a few minutes. But it transitions into the coronary sinus, drains into the right atrium. If you remember, the valve is known as the Thebesian valve. There are a few other tributaries that we are seeing here. One is this vein here. The easy name, the anatomical name, is posterior interventricular vein. It accompanies your posterior descending artery. It's also known in the literature very popularly as the middle cardiac vein, so that's another term you should remember. Apart from these, there are other veins which drain the posterior vein in the posterior aspect of the heart and the left lateral aspect, and they are termed posterior veins and the marginal veins. And they can drain variably into the great cardiac and the coronary sinus. So the point of transition, again, this is something which you may or may not see on imaging all the time, but one of the important ones is where the remnant vein, the oblique vein of Marshall, drains into the coronary sinus right here, which marks the demarcation between the coronary sinus and the great cardiac. Internally, it's marked by the valve of Houston, something you don't see on imaging. But the important thing is you kind of have a rough idea about where the great cardiac vein transitions into the coronary sinus. There are a lot of procedures which are utilizing coronary sinus, and therefore electrophysiologists in our place sometimes require these CTs for vein mapping. So about the cardiac resynchronization therapy, the target veins are typically the marginal veins and the posterior veins, which are highly variable not only in their size, but in their caliber and in the angle at which they drain into their respective veins. So having these kind of roadmaps can be helpful to the EP folks. So let's do this audience response question. It looks like a familiar case. We have seen it before as well. So what do you think is the name of this coronary vein shown by the arrow? Is it the coronary sinus, great cardiac vein, middle cardiac vein, or the anterior interventricular vein? And that is great. This is a difficult topic, but almost all of you got it right. It is indeed the middle cardiac vein, also known as the posterior interventricular vein. Now, talking about the abnormalities, and I want to show you this interesting case because this is something, initially at least, it was quite a blind spot for me to look at the coronary veins. We tend to look at the arteries, we tend to look at the cardiac structure, but often neglect the coronary veins. So ever since I've started looking at the coronary veins, I have found abnormalities, and it's therefore interesting to look at it. This is a patient who came in for an aortic assessment, and what you notice is that this patient has a coronary sinus osteoatresia. I'm showing you a single image, and it can be hard to believe, but this is a MIP image. You can see the middle cardiac vein coming in here, but there was no connection with the coronary sinus here. So there was a coronary sinus osteoatresia, also had a persistent left SVC. So let us see. What do you think is the direction of flow in the left SVC in this patient who has a coronary sinus osteoatresia, who has a left SVC coming into the coronary sinus? You also notice how small this caliber is. So let's see what everybody thinks. Think how the blood might be, how this coronary venous blood might be draining, because it's really not draining into the coronary sinus. So this is indeed great. This is a wonderful 2/3 of you got the correct answer. It's cranially directed. And the important thing to remember is normally an LSVC blood drains caudally. We all know that. But in this case, there is an osteoatresia, so there is no way for this blood to go into the right atrium through the coronary sinus. Instead, all the coronary venous blood is going via this left SVC through the brachiocephalic vein into the right SVC and right atrium. So this is indeed cranially directed in this patient. I'll just show you a brief companion case. So you can understand if you have coronary sinus osteoatresia, that coronary venous blood needs to drain somewhere. If it cannot go via the coronary sinus and the patient has this left SVC, it finds that venue, it goes via the left SVC all the way through the brachiocephalic right SVC into the right atrium. But this was a patient who had an atretic CS ostium but had no left SVC. So in this particular patient, again, this is the osteoatresia. What this patient has is, you nicely see it on the sagittal image, the coronary veins and the coronary sinus were draining into the left atrium. There was another connection with the great cardiac vein here. So this patient actually has these small connections with the left atrium. Obviously, it induces a tiny bit of shunt, but that shunt is not significant. It's a very small amount of shunt. But this is the way for that coronary venous blood to get back into the heart. So with this, we've covered our learning objectives, and I thank you very much for your interest.
Thank you so much. So that was a great introduction to normal coronary anatomy. And so we're going to follow that up now. Dr. Seelan Javidan Najad is going to be talking about anomalous coronary anatomy.
Thank you, Dr. Jacobs, and thank you, RSNA, for having me. If we can get the lecture up. So we're going to speak about coronary artery anomalies. I have no disclosures related to this lecture. Coronary artery anomalies requiring surgical repair are uncommon. Many are discovered incidentally. Some are suspected due to a difficult or abnormal coronary catheterization. And it's important for us to recognize and provide correct recommendations when we encounter a coronary anomaly. There are different ways to categorize coronary anomalies. One way is to go about the more traditional abnormal origin, course, and termination. Another way to look at them is based on dividing them based on what type of clinical management do they require. Anomalous coronary origin could be coming off the wrong sinus, or could be coming off another vessel, which in that case we call it a common origin, or it could be coming off a pulmonary artery. Anomalous termination, we give it the name coronary fistula, which could also be off another, it could terminate to another artery or to a cardiac chamber, either on the right side or the left side. And then there are anomalous courses, which are always accompanied by anomalous origins as well. And these are intra-arterial, retroaortic, transeptal, you may hear us call it septal as well, and pre-pulmonic. There are normal variants where the origin is normal, but the course is a little bit abnormal, such as when the patient has a myocardial bridge. So I made some diagrams here for you guys to see what I mean. If we look at the coronary sinus, right, left, and non-coronary sinus, we expect the right to give off, the right sinus to give the right, and then if the left main bifurcate. If there is a normal, we can talk about a double barrel left main, which is a normal variant where the two come off directly. And another variant is if we see it comes off center, even off the commissure, all of that's a normal variant of no clinical significance. But if it comes off the non-coronary sinus, and then obviously that's an anomalous course, and sometimes it can come off the PA, which in that case we'll see that very tortuous branches or arterial courses in that case. Here's an example of the wrong sinus. For example, here's a left-sided coronary artery coming off the right side, and we can see as it follows on, it goes towards the left side. So usually it could come off another sinus, or sometimes it comes off another artery like here, which is again a common origin. You can see what we expect to be the normal one, and then the other one seems to be coming off it from right after its origin. Anomalous origin of coronary artery from the pulmonary artery, we can call it a kappa. In this case, what happens is that even though the coronary artery is originating from the pulmonary artery, the direction of flow is from the coronary artery towards the pulmonary artery. So in other words, the pulmonary artery sumps the coronary blood away from the coronary system into the pulmonary artery. And that's because of the pressure difference there. And it results into a left to right shunt. These patients present at a younger age. Usually when they're an infant, in infancy, they can come with ischemia and heart failure. And if they present in adulthood, it's usually because a good collateral network has developed. It's important for us to differentiate this type of anomaly from one where the coronary artery originates normally and terminates into the pulmonary artery. So in this case, this was a case where we looked at the origin. There was, at the sinus, there was no left main, but we can see left anterior descending coming off the left main, but we can see the LAD, very dilated and tortuous, coming off the pulmonary artery. In terms of getting into the courses, the first type is an intra-arterial course. This is what we used to call a malignant variant. And what happens is that there's an anomalous coronary artery traveling between the aortic root and the pulmonary artery. If it's a retroaortic course, we can see that it goes behind the aortic root. So it's basically between the aorta and the atria behind it. And a prepulmonic would be going anterior to the pulmonary artery. So it's basically between the pulmonary artery and, or right ventricle outflow tract and the sternum. Kind of like a course where like a bypass graft would take. And the last one is the septal variant. Usually it's the left main or LAD that has a septal variant, comes off their opposite sinus. And it kind of looks like an interarterial course, except that it dives immediately into the interventricular septum and reemerges later on in the mid-anterior interventricular groove. Myocardial bridge sounds like that, but its origin is normal, its proximal course is normal, then it dives into the myocardium and reemerges normally. So this diagram is trying to show that. Here's the intra-arterial course, the retroaortic course, pre-pulmonic course. What happens with transeptal, it goes through the septum, comes out in the mid-anterior interventricular groove, and then branches. And then if it's, for example, here's just a diagram of the myocardial bridge, it originates normally, dives in, and comes out again. Here's an example of an intra-arterial course as opposed to a septal variant. It originates a little bit lower and it goes into the myocardium, coming out later. Retroaortic course goes between the aortic root and the atria, as opposed to pre-pulmonic course goes anterior to the pulmonary artery and right ventricle outflow tract. The last type is coronary termination abnormality or coronary fistula, where it could terminate into a venous structure, a pulmonary artery, or even a cardiac chamber. This also causes ischemia due to a coronary steal phenomenon, meaning that the coronary artery and its branches should terminate to basically provide flow on the myocardium, and this fistulous connection competes with the normal branches. So instead of the blood going towards the myocardium, it goes into the connection and goes in the wrong direction. So as time goes by, these fistulas get larger. And the larger they get, the shunt gets increased. And so because of this, and it takes time for the shunt to get, shunt flow to increase, these patients tend to present a little bit later in life. The most common age for presentation for fistula is actually in the 30s and 40s. Termination site, most common is actually pulmonary artery, but it could go into the superior vena cava, coronary sinus, right atrium, right ventricle, and very rarely into the left-sided, left atrium and left ventricle. So when that happens, you can tend to seek basically a very tortuous vessel terminating into a structure, and whenever it terminates there's going to be a blush of contrast because going into that area that was basically a little bit washed out because of saline that we get. Here's like the coronary sinus. So here's an example of a fistulous connection. Here's the left main, LAD, so it looks like a normal anatomy, and then this tortuous vessel here terminating into the pulmonary artery. So if I see dilated vessel, too large and tortuous, where I don't expect to see such a vessel like that, I would wonder if there's a fistula. If it's around the pulmonary artery, there's two things I wonder. Could it be an anomalous origin, or could it be an anomalous termination of the pulmonary artery? And in order to differentiate those two, I look at the aortic root, look at the sinuses, and see if there's a normal origin. If there's a normal origin, then it's a fistula. If it's not, then it's an anomalous coronary artery originating from the pulmonary artery. When an anomalous coronary artery terminates in a cardiac chamber, what we call that is a coronary cameral fistula. It could be in the ventricle, it could be in the atria, so it gets a special name to it in that case. And here you can see the communication into the right ventricle. The same patient, when you look at the stress and rest test, you can see there's some reversibility in the septum and anterior wall. This patient actually presented in her 70s, which is very remarkable for such a large fistula. But this started out small, and with age it got larger. So once the shunting of the flow away from the territory that we expect gets large enough, the patient's going to become more symptomatic. So now we can categorize it based in terms of how do we handle these cases. And we put them into 4 groups. One is the ones that need definite surgery or intervention of some kind. The other one could be a surgical possibility. The next one we're going to say surgical awareness. And last one is just basically clinical curiosity. When it's a definite surgical lesion, the way it's treated by reanastomosis, unroofing the coronary artery, or coronary bypass surgery. And the three that fall into this category are the anomalous origin of the coronary artery from the pulmonary artery, coronary artery fistulas, and if there's an interarterial course of anomalous left main or anomalous LAD. Notice I didn't put RCA here. So here's that case I showed you guys earlier where this origination of the LAD was from the PA. Notice because the flow we said is backwards. How does that LAD get its flow? Through collateral vessels from the normal circumflex and RCA. So if I look at the RCA, look at the other branch, this is a different patient. You can see basically tortuous vessels. Here's a different patient. We can see the origin of the RCA was coming off the PA. There was a lot of tortuous vessels, got very close to the sinus, but never really communicated with it, and then traveled down. So the flow is a shunt-like flow. And when you look at the opposite vessels, they're actually large too, because they're basically through collaterals providing flow to the PA, and then to the RCA, and from there into the PA. And here's a coronary catheterization of the same patient. Here you can see that the catheter is going into the ostium of the left main, so it's a selective injection into left main. And then through the LAD coming into collaterals, you can see it's going upward into the RCA, and that little, what looks like a waterfall, is it's going into the pulmonary artery. So I'm just going to let this loop again. Come down here, collaterals upward and there. So you can see the direction, even though the anomalous origin of is really the RCA. The left main was normal, but the whole other side is providing flow through collaterals towards that anomalous vessel and going to the pulmonary arteries. That's why this needs treatment. It's a big shunt that's happening. Coronary fistulas, again, could be from left to right or left to left shunt. Again, what we see are tortuous vessels. So here in this interatrial septum, we saw a lot of tortuous vessels. The RCA itself is dilated. This is where we expect to see the sinoatrial nodal branch. Way too large for that, way too tortuous. That's why it's not, it looks like dots here. We couldn't put it in one image unless I mipped it up. And then looking for the connection, we can see it went into the right atrium, right where the superior vena cava joined it. So it's a shunt from that branch going into the right atrium. And then this is a different patient where we can see that it's a fistula from the left anterior descending. Again, big network of tortuous vessels. Here's the origin was normal and then goes up into the pulmonary artery. The last of this category is the intraarterial course of the left main or LAD arising from the right sinus. One of the problems traditionally they said was a problem needing surgery was because, especially when the patient exercised, they said that what would happen was this patient would be in danger of a sudden death because of compression. Here you can see the LAD coming across. This is about the level of the valve here, and then left main came across, and then became the LAD and the circumflex. So this would be important. It's left main going intraarterial course, but the real thing that now we're talking about is when they take this intraarterial course, many times the angle that the coronary artery, that origin, comes off of that opposite sinus is it takes on this hairpin turn, and because of that, the ostium gets compressed, and beyond that, when it courses, this is that part, you can see it goes, many times it goes into the wall of the aorta, so it has an intramural course too. Because of these two, this angle getting narrowed, and this course that it gets more narrowed, and it's more likely to get compressed. Again, when you notice this, you can see here's where it's coming off from the right side. This is the valve plane. The pulmonary artery has a kind of sinus, just like the aorta does. So the valve plane is here. And you can see it's between the aorta and the pulmonary artery, and it goes backwards. And if I double oblique this, we can see that that's basically narrowed in that location. Now, what are the possible surgical lesions? These are the lesions that would require some sort of other type of imaging to see if this is a flow impeding lesion, if there's true ischemia caused by this anomaly. And in those cases, they do a stress test. A exercise stress test is better than a scintigraphic one in terms of revealing this type of ischemia. In our institution, we put the anomalous RCA with an interarterial course in this category. Many times, the type of anomalies are incidentally seen, for example, in our outpatient clinic for cancer, and these patients may not be symptomatic. So we want to have this patient get a stress test. The septal variant usually causes no problems, rarely can cause ischemia. The myocardial bridge, we said, was basically a normal variant, but if it's long and deep, it could be the cause of ischemic findings, again, if the stress test is positive in that territory. And important to think about the single ostium. I'll go into that. So interarterial course of the anomalous RCA originating from the left sinus. When you look at it here, it comes off the left sinus. It's a separate origin from the left main, and it's traveling here. If I double oblique it through here, you can see that it's nice and round. But again, it doesn't look compressed, but this patient had a stress test. Top row is the stress, the lower row is the rest side, and you can see they're pretty identical. There is no reversibility of any kind. So this patient, this anomaly didn't cause ischemia. As opposed to this different patient, you can see that the ostium is much more narrow. It looks slit-like if we cut through it here and we look at the image, it's slit-like. And this is definitely suspicious for it to cause ischemia. And when you look at the stress test, we said this is the RCA. So RCA, especially if it's dominant, gives off the PDA and the inferior wall, and you can see the reversibility here. So this definitely was the cause of ischemia, and the patient did go for surgery. The septal variant starts lower, travels lower than the interarterial course. So where it comes off, instead of traveling in this direction to go between the aorta and the pulmonary artery, it dives inward and immediately originates from the opposite side, immediately goes, and you can see it surrounded the myocardium and the septum, and then later on reemerges in the anterior interventricular groove. If I wanted to put this whole course, I can MIP that up. Kind of looks like it's in the chamber. It's actually not. It's in the myocardium to show its course as this one took on. This was the left main coming off, and then it branched into the LAD and circumflex. And if I were to double oblique it here, you can see, again, here's the sinus of the pulmonary artery. This is the pulmonary artery aorta. It's not really interarterial. It's really lower, and this is the septal variant. This tradition is considered to be protective and is supposed to not cause any kind of ischemic problems. But if the patient's symptomatic and we don't find anything else, then it's possible that that could be a cause. This patient has enough atherosclerotic disease here that this has another cause here to explain it. Most myocardial bridges are benign. They're shallow. They're short segment, normal origin, goes down, comes out. But this particular patient was young and was clearly symptomatic. They did a stress test. It was positive, and it was a longer segment, a little bit deeper. Again, if we see that, then we may question it. But in most cases of a myocardial bridge, we just ignore it and consider it normal variant. Now, I put this one in here. I put surgical, but I really should put intervention. And I put this only because I want to bring this to your attention, that if someone has a common ostium, if the course is what we consider to be traditionally a benign course, or like a non-surgical course like the retroaortic course here, if it's a common ostium and that common ostium has atherosclerotic disease, now a larger territory is involved. And this patient, we have to be thinking about that when there's a common ostium. So this is an anomaly or normal variant you can consider, but it's an anomaly in terms of the common origin part of it. And what happens is, it's an anomaly when you have that, and this atherosclerotic disease makes it much more significant, even though the retroaortic course is traditionally not as much of a problem. Surgical repair, they can do coronary artery bypass grafts. Sometimes, if we can identify that this is traveling in the wall of the aorta, unroofing can be done. And this has to go with which center you are, if your surgeons are doing it. So this is before treatment. This is MIP'd up, so if I want to really see how it is, I have to take the MIP, the maximum intensity projection, down to normal thickness. And when you look at it, that ostium is narrowed, and it does seem like it's traveling in the wall. So if they resect that little bit here, that looks like a flap, then suddenly the ostium will be displaced more laterally, and instead of coming off like this narrow turn, it'll come off a little bit more vertically, and this is after unroofing. This type of surgery is done endovascularly, so it's less invasive, and again, if your center does that, that could be good to know. So providing information in terms of how long of it is traveling in the wall is very helpful. If the patient has anomalous coronary artery coming off the pulmonary artery or fistula of any kind, they re-anastomose it to the right location, or sometimes they use a bypass conduit. This is a case we came across on MR, and we were looking at, here's the aorta, here's the pulmonary artery, here's the right ventricle outflow tract. We saw this dephasing jet, but the valve was normal. This was below the valve plane. We saw this rounded thing going across, which I go along the course of it. It's going in this way. Went into the history. This turned out to be a patient who had the left main coming off the pulmonary artery in childhood. What they did was they basically went through the pulmonary artery to make it to the aorta because it was long enough to go into that. They used a conduit to help do that. So it went through the lumen of that. It was an interesting case, or it's not the usual type of treatment. Surgical awareness are cases that don't need treatment, but if they're going to do surgery for a different reason, they need to know about it. Pre-pulmonic course, this is again what traditionalists call the benign type. Pre-pulmonic course, retroaortic course, and then I put this here too because when people have anomalous courses, there's more turbulence and they could have atherosclerosis in unusual locations. I'll show you an example. So here's a retroaortic course of a patient. Here's this origin here becomes the LAD. Here's the RCA. You can see the circumflex comes off the RCA, has a common ostium, no atherosclerotic disease here, and it goes posteriorly between the aorta and the left and right atrium. This is basically not important to be treated in itself, but if this patient is going to have an aortic valve replacement with open surgery, they need to know about that. Here's a pre-pulmonic course where we can see that the left main coronary is traveling anteriorly, and as it's going anteriorly, if this patient is going to have a sternotomy for any other reason, they can transect it. And then here's a patient who had a left main with a retroaortic course, but there's that atherosclerotic disease along its course in different locations. If they are going to go in and do and try to treat the atherosclerotic disease with endovascularly and try to go all the way out into that to put a stent there, that could be problematic because of this strange course. So they need to know about that. And so it's a matter of surgical awareness. And they may decide, look here, we can't do that, and instead we're going to do a bypass graft. Here's a different patient that's had a myocardial stress test. Here's the perfusion part of the exam where you can see anterior and the lateral wall here. On stress shows a hyperperfusion, which is a Stark area. On rest, it reverses. And on delayed shows that this is not infarcted. The only infarcted part was this little small area here. So this patient has ischemia. When we look at the course, this is a left main again, traveling anterior to that. It has a pre-pulmonic course. And in this case, the course itself is not the problem, but there's a lot of atherosclerotic disease here, right where it bifurcates. Again, probably from the weird tortuosity causes more turbulence and more atherosclerotic disease. And that, again, could affect how they treat this patient for the atherosclerotic disease. And lastly, surgical curiosities, and some of these are variants that Dr. Agrawal showed you, high origin off the sinus of Valsalva or the commissure, or separate origin of the coronary sinus. Here's an example. Here's the right, left, and non-coronary sinus that we follow up. When we get above the level of sinus, as we can see this RCA coming off, a little bit medially coming off here, that is just a normal variant. Coming off the tubular part of the aorta, above the sinuses is just a variant. And here you can see it again. Here's the right sinus, RCA coming up, a little bit more anteriorly, but still above the RCA. You can't see your mouse unless you do it on that screen. Oh, I see. And then on the left side, you can see it's coming off center here. And with that type of thing, it's going off there. The other thing that's a surgical curiosity is when people have congenital heart disease. When there's congenital heart disease, the aortic root could be normal, and it's normal for that type of congenital heart disease. People who have transposition of the great arteries, the coronary arteries follow which side. So in like detransposition, the right ventricle's on the right side, left ventricle's on the left side. There is no switching of the ventricles, but the right and left coronary arteries on the same side. But what you find is a non-coronary sinus is facing anteriorly. Normally it doesn't. Normally it faces the intraatrial septum. And that's completely normal for this patient. Tetralogy flow, what happens is the whole aortic root rotates in a clockwise direction. So instead of the right sinus facing this way, the left facing that way, and the non being posteriorly, because of that rotation, sometimes it even faces anterior and towards the left. It may look like the RCA is coming off the right sinus. It may look like this one is facing posteriorly, and you think, oh gosh, the left main is coming off the non. It's not. That's expected in tetralogy of Fallot. So in summary, definite surgical lesions, intraarterial course of left main and LAD, a kappa and coronary fistula. Take-home point here is if there's an intramural course, unroofing is done. Possible surgical lesion, intraarterial course of the RCA, some myocardial bridges and septal courses, some of them, and single common origin at the ostium. And take-home point is this requires a stress test and multidisciplinary discussion. If there's a retroaortic course or prepulmonic course, it's important for different types of surgeries, and take-home point is atherosclerosis can pose a challenge to endovascular repair in these cases. And then there's different variants or abnormal orientation of the root in complex congenital heart disease. In these cases, we don't do anything about them. Thank you. So now what I'm going to do is I'm going to go through cases, and you'll see how we basically approach these cases in real life, and then that's where our audience response questions will show up. Can everybody hear me on this microphone? Okay. So anytime I approach a case, what I always do is I start from the axial images. So these are the axial. This already sets the planes up for us. And if I want to look at the root, what I do is I put the crosshairs on the root. You can see that we have a coronal and sagittal image here. If you turn this such that now this, what was horizontal, basically is parallel to the aortic valve, let's go in and out of plane here. This one actually turns out to be there. And the more vertical one is along the axis of the aorta. If we go back to this axial image, now we can see the sinuses now look equal in size. If we didn't do that, then because of the tilt, it makes it look awkward. And that's how I usually start when I'm looking for coronary arteries. Sometimes when we double oblique things, it could make it seem hard, make it so distorted that it's hard to tell which sinus is which is which. So the sinus that basically faces the septum is going to be the right side. The sinus that faces the intraatrial septum here is going to be the non. And the sinus that's closest to the left atrial appendage, this structure here, is going to be the left sinus. So right sternum, did I say septum? It's sternum. Right sternum, atrial appendage would be left. Intraatrial septum would be the non-coronary sinus. Now I'm going to take my arrows off here. This up. As we're looking at it, let's go to the left sinus and see if there's a coronary artery that's coming off of it. And we see nothing. There's nothing coming off. There's some vessels traveling close to it, but there's nothing coming off of it. But we do see this branching here, which would be the LAD circumflex. The left main is where they come together, and let's go back. We can see it's traveling here between the aorta and the pulmonary artery. Again, this is the pulmonic valve level. This is the pulmonary artery already, and it's going between the aorta and the pulmonary artery. So this is an intraarterial course. The left main is coming off this. We said this is the right sinus facing the sternum, coming off that from a separate origin from the right side with an intraarterial course here. So just to show the right side, the right sinus here, the right coronary artery gives off a normal right coronary artery with the SA nodal branch, which we expected to go towards the intraatrial septum. So in regards to this anomalous coronary artery, which I have the arrow in pink, what are we going to do? Can you please show the ARS question? I'm not seeing it. Do you have the ARS question coming up? Should we come in here? Yeah, no, I got it. first question is, should we do nothing? Notify the surgeon or cardiologist prior to an unrelated surgery or intervention? Stress test to assess the hemodynamic significance of this, or surgical repair of this anomaly? Please answer in your pads. Can we have the answers come up, please? Okay, good. So most people said option D. This is an intra-arterial course. That's a correct one. This doesn't require interdisciplinary discussion because we said anytime the left main and LAD travels in an intra-arterial course, that always requires some sort of surgical repair. If it's the RCA doing that, then yes, we may question that. So our next case here, we're going to do the same thing we did before. I'm going to put it on the root, double oblique it, parallel to the valve. Here, parallel to the valve again. Now I have what looks like a clover. And we're going to look at the left sinus first. We see this is the left sinus facing left atrial appendage. And there's no coronary artery coming off of it. This is the nothing coming off of it. But from the right, we see two arteries. One is going towards the right atrioventricular groove here. That is the right coronary artery. But there's another one traveling in this direction, in the opposite direction. So the question is this an intra-arterial course of the left main, or is this a septal variant? So I have to see, is it diving into the septum, or is it coming upward in between the pulmonary artery and aorta? Looking at it, it seems like it's going downward. And I'm going to blow this up. You can see that it's surrounded by myocardium. Going in the septum here, and then it reemerges here in the anterior intraventricular groove. So this would be the septal variant. Going to put this on the vessel here along its course. And when you look at it here, I'm going to blow this up here. You can see again, it's pretty low. This is where the valve plane is. Put a line here. This is where the valve plane is for the pulmonary artery here. It's very low. It's within the septum. This is the septal variant. So can you please put up the ARS question, please? Same question again. Do we do nothing? Do we notify the surgeon and cardiologist prior to unrelated intervention, stress test that says hemodynamic significance, or surgical repair of the anomaly? Please answer the questions on your pad. And can we see the answers? Okay, so this is very good. So basically, we always say the septal variant usually is something that doesn't cause an abnormality, but if this is a patient, 47 years old, we find no other atherosclerotic disease, has real problems, symptoms, and so there's some disease here, but if that was not stenotic, so the question would be, is this a flow-reducing anomaly here? So the patient would require stress tests. Very good. The next case I'm going to show you here is this one. Sorry about that, it gave me the wrong series. Do the same thing we did before again. Go to the root, double oblique it. So it's a long, basically on both of these, the red line is parallel to the aortic valve. We look at the sinus, we see that, look at the aortic root now, it looks like a clover again. This one is facing the sternum, it's the right one. This one is facing the intraatrial septum, it's a non-coronary sinus, and this one is closest towards the left atrial appendage, this structure here is the left sinus. And starting from the left sinus, do we see anything coming off of it? There's a vessel close to it, but it's not coming off. this guy here. We can follow it. It travels between the atria and the aortic root, really low down. I'm now below the level of the sinuses. Some atherosclerotic disease there. And then it comes off here, off that right sinus, right over here, with a separate origin from the RCA. Since we didn't see anything coming off the left side, and I don't see any other anomalies here, and we follow it, we can see now it branches into LAD, and then it gives off this branch here, going this circumflex. This is a left main with an anomalous course, anomalous origin, obviously, too. It's arising from the right side, and it has a retroaortic course here. Can you have the ARS questions again? I need an ARS question set up. All right, same questions here. Which one of these options do you think should be done for anomalous coronary artery with a retroaortic course? Now, my question is not about the atherosclerotic disease, it's only about its course itself. Regarding that course, what do you think is the best recommendation? And answers? So the best answer here is that we basically do nothing for this if I'm ignoring the atherosclerotic disease, with it traveling posterior to the aortic root. Next question, next case here. Going to set it up the same way, so I'm going to put the crosshairs on the aortic root. Here, make it parallel to the aortic valve, or along the course of the aorta, again parallel to the valve. And looking, I'll blow this up for you. Looking at the origins, here's the left sinus, left main is coming off of it, it's pretty large in caliber. Here's the right sinus facing the sternum. There's a right coronary artery here. This little branch is a SA nodal branch, so that's normal. Following the course of the RCA here, we can follow it. It gives off where it's supposed to do that. But coming off to the other side, here's the LAD, there's a Ramus branch here. Here's this circumflex, very large, larger than what we usually see, very tortuous. Now I'm seeing a network of vessels. So if I see a network of vessels like that, it's either anomalous origin or it's anomalous termination. We saw the origins, they were normal. We're going to follow it. And Dr. Agrawal did a very nice job in terms of going over the venous anatomy here. This is the, double leak this for you. This is the coronary sinus here. And you can see the coronary sinus on this one too. It's supposed to have venous blood. Instead, this pink arrow is showing the coronary sinus. It has bright blood. So when we follow this network here, we can see that this tortuous vessel comes and it terminates in the coronary sinus. This is a fistula coming from the circumflex and terminating in the sinus around here, where we can see that before that, the blood in the coronary sinus was dark. It hadn't been opacified yet, but at this point onward, where you see the pink arrow, you can see bright. So the connection is somewhere around this neighborhood, around here where these little dots are. So this is a fistula. Can you put the ARS questions up again? All right, same options. What's the best answer here? And can we see the answers, please? Good. So we said every fistula needs repair. These fistulas get larger with time when patient presents symptomatically. Basically what's happening is this is drawing flow away from the myocardium. We said the circumflex feeds the lateral wall of the myocardium and it's directing it towards the coronary sinus. So it's shunting it away from the left side. The coronary sinus drains into the right heart, so it's a left to right shunt happening here. And because of that, this needs repair. What they did with this patient is they basically went in and they just put an Amplatzer device within it. But sometimes they coil these to close it off. And then after that, the patient did well. I'm going to show you a different one here. It's 4. Starting out with just looking at this 3D rendering, we can see there's something abnormal because here's a right ventricle, and we shouldn't see much anterior to it. Now, we know the conus branch of the right coronary artery could travel anterior, and Dr. Agarwal showed you a very nice anterior collateral pathway when there's a vucin arch, but here, we have to see what's going on with the root, with the course again. So here, let me double oblique that the way I showed you guys. We're going to put the crosshair here, turn this parallel to the valve plane, again here also. Now we have the shape of a sinus. This is the right sinus. It's facing anterior towards a little bit towards the left, the sternum. Here's the left sinus, is facing the left atrial appendage. This is the left sinus. And this one is facing or closest to the intraatrial septum, so this is the non. And we'll start with the left like we always did before, the yellow arrow going towards it. We see nothing coming off. I want to see if there's anything coming off the non-coronary sinus, this second arrow here. Nothing coming off there, so that's fine. Now we'll look at the right sinus, get rid of that arrow, here. And coming off of it, we see this 2 vessels with a common origin. Now the origin's the ostium is nice and open, and this one dilated goes off towards this direction here. Looks fine. This is a RCA, very dilated and tortuous. But coming off over to here, we can see that the left main was missing. So following that with these arrows, we can see it travels anteriorly between the great vessels and the sternum. Is taking here, it's anterior to the right ventricle outflow tract and the pulmonary artery. Here, that's the prepulmonic course. So if I could thicken that up, maybe I can show the course in one image. It's taking a prepulmonic course. And then right here at this level is where it's bifurcating. This becomes, this pink arrow here becomes, let me make it pink. Okay, it's not doing it. This pink arrow here, okay, the yellow arrow here, it becomes the LAD. And this other pink arrow here becomes the circumflex. I'm going to show it to you on the axial images without mipping it here. So as we follow it here, we can see it already bifurcated. Let's follow and see where they go. Get rid of this arrow. As we go, the one that was more anterior continues on, goes into the anterior ventricular groove, continues on downward. This becomes the LAD. The other one, I'm going to get rid of the extra arrows here. The more posterior branch off of that ascends back up the anterior interventricular groove, and then eventually comes down this way, here. Eventually it comes backwards and goes into the left atrioventricular groove between the left atrium and left ventricle, so it's a circumflex. And when you see an anomaly like this, because the circumflex is traveling where the proximal LAD would have come, sometimes we see small septal perforators that we would have expected to come off the LAD, to come off of that anomalous course. Sometimes even gives a branch similar to a diagonal. That's not unusual when you see an anomaly like this. So prepulmonic course, it bifurcated right over here, anterior to the pulmonary artery went. So let's go back to our ARS questions, please. Can you bring up an ARS question? Same options here. What's our recommendation for this? Do nothing, notify the surgeon and cardiologist prior to unrelated surgery or intervention. Stress test to assess the hemodynamic significance or surgical repair of the anomalies. Please put in your answers. And let's see the answers, please. So this is one that we basically would notify the surgeon cardiologist prior to unrelated surgery. And this is our last case here. So if you guys have any questions, please come up forward, and be happy to answer the questions. Thank you very much.
Thank you. I want to thank both our speakers for excellent presentations. Just to remind you, for those of you who might have walked in late, each of the 3 parts has separate CME that you can receive. So make sure you put in the CME for this part, and if you're staying for the other 2 parts, make sure you put them in for each of the parts. Okay, you get CME now for each of the 3 parts. Thank you.